My name is Arjun Balar. I'm a medical oncologist, and I am the director of the GU Medical Oncology Program at NYU Langone Health's Perlmutter Cancer Center. I'm also medical director of the Clinical Trials Office and a clinical investigator dedicated to bladder cancer research. So our study is a multi-center phase 2 trial that tested the addition of pembrolizumab, which is a PD-1 antibody added to standard trimodality bladder preservation therapy, which involved a maximal transurethral resection of the bladder tumor along with hypofractionated radiation treatment and twice weekly gemcitabine chemotherapy as bladder preservation treatment for muscle-invasive bladder cancer. The entire concept was the idea that there's obviously, for patients with muscle-invasive bladder cancer, either cystectomy with perioperative cisplatin-based chemotherapy is a standard of care, but so is bladder preservation treatment with this trimodality bladder preservation treatment involving a resection of the tumor followed by concurrent chemoradiation. We wanted to offer this treatment to patients who elected bladder preservation, but also test the role of the addition of pembrolizumab added to it, which is a PD-1 antibody. There's a long-standing history in kind of preclinical and as well as clinical evidence emerging that immunotherapy synergizes potentially with chemoradiation. There's evidence from randomized trials in non-small cell lung cancer and preclinical evidence as well in mouse models as well. And what we wanted to test is, what is the role for combining immunotherapy in bladder preservation treatment in muscle-invasive disease? The eligibility criteria were relatively straightforward. These are patients with clinically localized muscle-invasive bladder cancer, clinical T2 to T4A node-negative disease. Urothelial cancer as the primary histology was required, but mixed features were permitted. Adequate performance status. Patients could either be cystectomy declining or patients who were not good candidates for surgery. Perioperative chemotherapy was not allowed on this trial. And these are the primary eligibility criteria for enrollment in this trial. Sure. So in the treatment of the treatment schema in this study involved all patients who were enrolled. It involved actually first a safety lead-in of 6 patients to assess safety. We found the treatment was well tolerated in the first 6 patients, and then we moved on to an efficacy cohort of 48 patients. In all of the patients, all patients received an initial lead-in dose of pembrolizumab, followed by 2 to 3 weeks later, the standard maximal transurethral resection of the bladder tumor, followed by several weeks later, concurrent chemoradiation and pembrolizumab. The radiation schedule was 52 gray over 20 fractions. The gemcitabine chemotherapy was administered concurrently, twice weekly, 2 days apart at 27 milligram per meter squared. And the pembrolizumab was also administered concurrently at 200 milligram standard dose every 3 weeks for 3 doses. And then, 12 weeks after the last dose of radiation, patients underwent a TUR of the tumor bed, a urine cytology, and cross-sectional imaging. And then patients were followed for, the key efficacy measure, which was bladder intact disease-free survival. That was the primary endpoint of this study, which was essentially to measure all of the ways that our treatments can fail our patients. So BIDFS, or bladder intact disease-free survival, measured the first of either a muscle-invasive recurrence, regional or distant metastasis, the need for cystectomy or death. And our expected rate, based on a control series, the RTOG pooled analysis, which was published in 2014, the expected rate at 2 years was roughly 60% when we looked at that old data set. And that is what is expected with chemoradiation alone. Our study in the 48 efficacy enrollment population was powered to detect a 20% absolute improvement on that 60%. So we were shooting for 80% at 2 years. The median follow-up in the patients that we enrolled in this study for the entire study cohort of 54 patients was about 15 and a half months, and in the efficacy cohort was about 14 and a half months. So this is a fairly preliminary analysis of the outcomes. But when we looked at the bladder intact disease-free survival for the patients that were enrolled, the estimated 1-year rate is about 88%. And when we look at the overall study population of 54 patients, which so obviously expands it by a little bit and slightly longer follow-up, it's 89%, which is very, very encouraging in this very early analysis and suggests that we're kind of well on our way to meeting our primary endpoint. Obviously, a key measure in a single-arm study is not just efficacy, but obviously safety. This was the first study to really look at the combination of PD-1 along with hypofractionated radiation treatment and chemotherapy in muscle-invasive bladder cancer. Overall treatment was very, very well tolerated. The rates of grade 3 and 4 adverse events were of low frequency and severity. When we tend to focus on the immune-related toxicities and what is the risk of potentially enhancing these immune-related toxicities when you start combining with radiation and immunotherapy. Also, when you're looking at pelvic radiation, we found that 9 of the 48 efficacy cohort patients required systemic corticosteroids at the time for what was suspected to be an immune-related adverse event. Those individually included, cases of arthritis or arthralgias, 2 cases of transaminitis, and a few rare cases of things like nephritis, protein-losing enteropathy, a patient with polyneuropathy, and then 1 patient who developed a colonic perforation in the RT field. But overall, patients tolerated treatment really, really quite well on study. So the biospecimen collection schema in this trial was designed really to collect specimens serially. So all patients at the time of enrollment were required to submit untreated tumor tissue from their muscle-invasive bladder tumor specimen, and then also tissue at the time of maximal TURBT, which was only exposed to a single dose of anti-PD-1 antibody. And then finally, tumor tissue at the end of treatment, which was now exposed to both PD-1 antibody, chemoradiation as well. And then blood specimens were collected serially throughout treatment as well. So essentially, this trial was really designed to interrogate kind of the individual and combined contributions of these treatments on both local and systemic anti-tumor immunity. So far, the analysis is currently still ongoing. And what we have so far only been able to analyze is the PD-L1 expression data from the baseline tumor specimens. And what we have found is that of the 45 patients whose tumors have been evaluable, the positivity rate, or the PD-L1 positivity rate, which is an MPS score of 10 or greater, is about 46.7%. So let's just say 47%. Which is in keeping with what we have seen in other similar patient populations of muscle-invasive bladder cancer, where we're looking at the 22C3 assay, which measures both tumor cells and immune cells. This is a surrogate score. This is called MPS, which is called a modified proportion score, which is fairly akin to a combined proportion score. Which is the CPS score, but essentially, what we find is that, close to 45 to 50% of patients will be considered positive. What we later hope to demonstrate in the ongoing analysis is that patients' PD-L1 status might actually change in terms of the tumor on treatment, and similarly that we may expand tumor-resident T-cell clones in the periphery either after single-dose PD-1 or subsequently upon the initiation of chemoradiation, which would suggest that the addition of chemoradiation enhances anti-tumor immunity and perhaps immune surveillance that could lead to enhanced tumor control and the reduction of the risk of metastases later on.